A 52-year-old known alcoholic with recent variceal hemorrhage was admitted in status epilepticus. Blood showed deranged liver function tests, coagulopathy, and hypoalbuminemia. I am showing you an axial FLAIR MRI scan. Describe the findings.
Right, so the axial FLAIR MRI demonstrates bilateral, largely symmetrical areas of high signal intensity in the cerebral cortex and thalami. This cortical hyperintensity predominantly involves the insular and cingulate gyri. There is notable sparing of the occipital and perirolandic cortices. The white matter appears unremarkable without focal lesions.
I am showing you the corresponding diffusion-weighted sequences. What do they demonstrate?
The diffusion-weighted MRI shows matching areas of hyperintensity in the bilateral thalami and cortical gyri. The corresponding apparent diffusion coefficient map confirms true restricted diffusion, indicating cytotoxic edema. These restricted diffusion changes are symmetrical and correspond to the FLAIR signal abnormalities.
What is the diagnosis? Explain the underlying pathophysiology and the clinical precipitating factors.
The diagnosis is hepatic encephalopathy. Pathophysiologically, background acute or chronic liver failure impairs ammonia metabolism by the hepatocytes. Furthermore, portosystemic shunting allows blood to bypass the liver entirely, increasing systemic ammonia levels. Ammonia readily crosses the blood-brain barrier, leading to astrocyte swelling, cytotoxic edema, and neuronal dysfunction. Common precipitating events include gastrointestinal hemorrhage, active infection, constipation, or acute renal failure.
What are the key differential diagnoses? How do you differentiate them on MRI?
Differentials include post-ictal signal change, acute anoxic ischemic brain injury, and viral encephalitis. Post-ictal changes can occur in patients with status epilepticus, but are typically asymmetrical and more generalized. Anoxic ischemic damage typically involves the deep gray matter nuclei and the perirolandic cortex diffusely. Encephalitis would show an asymmetric predilection for the temporal lobes and limbic system.
What other MR features or spectroscopic findings can be seen in chronic liver failure? How would you manage this patient as a radiologist?
T1-weighted sequences often show bilateral, symmetrical high signal within the globus pallidus and subthalamic nuclei, representing manganese deposition. On MR spectroscopy, there is an elevated glutamine peak accompanied by decreased choline and myoinositol peaks. As a radiologist, I would recommend immediate correlation with serum ammonia levels to confirm the diagnosis. I would communicate these findings immediately to the referring clinician and refer the patient to the gastroenterology and hepatobiliary teams for prompt medical management.